Hello, in this video we're going to talk about acute coronary syndrome, which is a syndrome characterized by a reduction or occlusion of blood supply to the heart. And so we begin by revising the anatomy of the heart just quickly. So the heart consists of 4 chambers. The left ventricle here will pump blood to the rest of our body via the main big artery, the aorta. And coming off the aorta are 2 main arteries which supply the heart muscles itself. These are the right coronary artery and the left coronary artery. The left coronary artery further divides into 2 main arteries, the left anterior descending and the left circumflex artery. These arteries supply the heart muscles, the cardiomyocytes. Zooming into the area, we can see the artery here bringing blood and therefore bringing oxygen to the cardiomyocytes. Thus, it will result in a healthy cardiomyocyte. However, over time, atherosclerotic plaques can build up within these coronary arteries. And this is usually due to non-modifiable risk factors, such as aging, male sex, family history, and certain ethnicities such as being Caucasian. Now, the buildup of plaques can cause a reduction in blood flow to the area, to the cardiomyocytes, leading to poor oxygen supply. This can cause symptoms such as angina, chest pain, when people are exerting themselves. This is because when you exert yourself, the heart needs more oxygen and so needs more blood supply. But because the vessels can't meet the demand of the heart, you get angina as a result. Angina can be either stable or unstable. In unstable, you have chest pain even when you're resting. And this is, of course, a lot more serious. But, of course, the plaque can get worse, and it can even rupture, causing thrombosis. But the vessel is not totally occluded here. And this is what we can call a myocardial infarction still. The infarction of the myocardial tissue occurs distally to where that vessel supplies, and so there's ischemia proximally. This is referred to as a non-STEMI. And usually other risk factors contribute to this progression more rapidly. And these risk factors are the modifiable risk factors usually. And these include smoking, hypertension, having uncontrolled dyslipidemia, poor diet, obesity, diabetes, and having a sedentary lifestyle. Now, the rupture of the plaque can also result in a total occlusion of the blood vessel, of the artery. And this means no oxygen will go to the heart muscle cell in that area. This is also a myocardial infarction, causing death of cardiomyocytes distally, and then it will slowly progress proximally unless the occlusion resolves. A complete occlusion of the coronary artery causing an infarction is called a STEMI. So, in an infarcted muscle cell, you have cardiac muscle cells which undergo necrosis, specifically a process called coagulative necrosis. Now, STEMI and non-STEMI, as well as unstable angina, are what we refer to as acute coronary syndrome. And again, acute coronary syndrome is a syndrome where you have a reduction in blood supply to the heart muscles or a loss or total occlusion, and so no supply of blood to the heart muscle cells. And so acute coronary syndrome presents with very similar symptoms, and it is a medical emergency. The clinical presentation include central chest pain, usually described as a crushing sensation or heaviness, as well as tightness around the chest. This pain can radiate to the neck, jaw, and left arm. You can have diaphoresis because of sympathetic activation, feeling of impending doom, and nausea and vomiting from parasympathetic response. It is important to remember that chest pain that occurs while exerting, and if a person rests and the pain goes away, this is usually stable angina. And remember, unstable angina, you still have pain, chest pain, when you rest. Differential diagnosis of a myocardial infarction include those that cause also central chest pain or pain around the chest. And these include pericarditis, inflammation of the pericardium, aortic aneurysm, dilatation of the aorta, endocarditis, infective endocardium, pericardial effusion or tamponade, which is essentially presence of fluid within the pericardial sac, and anxiety is another very common differential diagnosis. You have other ones such as pulmonary embolism, where an emboli lodges in the pulmonary arteries or the capillaries, and this can cause pleuritic chest pain. Finally, there's esophageal rupture, which is another medical emergency and a good differential. Now let's look back at the site of infarction. Now, if a cardiac muscle cell dies, they release things in the blood. The cardiac muscle cells are made up of myosin and actin filaments, which are very important in muscle contraction, as you know. Actin have these things called troponin on them, which usually helps in the contraction process. There's also enzymes around the area, creatine kinase MB, which are important for energy transfer of ATP within the cell. Anyway, when the cardiac muscle cell dies, necrosis, the troponin and the CKMB get released into circulation, and these are measured to see if the heart muscle necrosis has occurred, essentially. And so if we were to draw a graph with time on the x-axis and serum cardiac markers, not enzymes, on the y-axis, we can see that troponin levels rise very rapidly and peaks about day 2 after the onset of chest pain before dropping down. Creatine kinase MB rise also rapidly, but not as high, and drop off a lot faster. Thus, as you can see, measuring cardiac markers, especially troponin, is very useful and important to help diagnose a STEMI and also a non-STEMI. On a side note, in stable angina and unstable angina, the cardiac markers, such as troponin, are not elevated. So if someone presents with those signs and symptoms of acute coronary syndrome, such as the central chest pain radiating to the left arm, you must perform investigations. And these include an ECG to check signs of a STEMI or non-STEMI, a full blood count, EUC, glucose, lipid profile, and of course, most importantly, cardiac markers or cardiac enzymes such as troponin and creatine kinase MB. But usually troponins are the only one ordered. An X-ray is also useful to rule out other differentials if you suspect them. But it is important to not delay treatment. On the chest X-ray, you might see sign of cardiomegaly. So let us now look at the ECG changes in acute coronary syndrome, beginning with unstable angina. The ECG, also known as the electrocardiogram, is very important to diagnose acute coronary syndrome, specifically STEMIs or non-STEMIs. However, 20% of ECGs may be normal initially. ECG shows 5 main waves, which correlate with parts of the heart while it's contracting and relaxing. These are the P wave, QRS complex, and the T wave. In unstable angina, you don't usually see any ECG changes. It is usually normal, or you can see a T wave inversion, so a dipping of the T wave. To understand the pathophysiology of unstable angina, as well as the other acute coronary syndromes, let us just recap the coronary arteries and the heart, the ventricles here. So you have the right and left coronary arteries, which are the first 2 branches of the aorta. The left coronary artery divides and forms 2 other big arteries. The left anterior descending, which supplies the anterior and septal parts of the heart, and then the left circumflex artery, which supplies the lateral wall of the heart. Myocardial infarction or heart attack tends to occur within the left anterior descending, and then the right coronary artery, and then the left circumflex. If we take a cross section of the heart like this is what it would look like. And here is where the right ventricle is and your left ventricle. This in front here is the left anterior descending, which again supplies your anterior wall of the heart as well as your septum in the middle. This is your left circumflex artery, which supplies the lateral wall of your heart. And at the back, wrapping around, is your right coronary artery, supplying the right wall and posterior wall of the heart. But now we will mainly focus on the left ventricle. Of course, you have the other layer of the heart called the pericardium, which essentially is a sheath that wraps around the heart and actually wraps around the coronary arteries as well. Let's take a closer look now at the left anterior descending artery and what happens in unstable angina, which make up one of the 3 types of acute coronary syndrome. So here is the cavity of the left ventricle. The 3 layers of the heart from the inside is the endocardium, myocardium, and the epicardium. Epicardium also make up part of the pericardium as well. Again, here we are focusing on the left anterior descending artery, which is the most common artery affected in heart attacks. Now, in unstable angina, you get reduction in blood supply to the heart muscle as a result of the plaque, and which is partially occluding the artery. And so you get ischemia to the muscle wall, but you don't get infarction. And this can occur at rest and can cause symptoms of angina, the chest pain. However, unstable angina can progress to a non-STEMI. In a non-STEMI, you get significant occlusion of the artery because of a ruptured plaque, subsequent thrombosis, leading to poor oxygen supply. But the artery is not fully occluded. The significant reduction in oxygen supply to the muscle wall causes infarction distally and ischemia proximally to the artery supply. The infarcted area is called a subendocardial infarction. Interestingly, the endocardium is not infarcted because it is receiving blood straight from the ventricle, the cavity where the blood pools essentially. Subendocardial infarction is a characteristic of non-STEMIs. Non-STEMI is called non-STEMI because on ECG you do not see a ST segment elevation. Rather, you see an ST segment depression, and this is the characteristic finding of a non-STEMI. A non-STEMI can progress yet further or can result from a transient STEMI. A STEMI again is characterized by a ST segment elevation on the ECG. What happens in a STEMI is you have a complete occlusion of the artery essentially because of the ruptured plaque, subsequent thrombosis, causing complete occlusion. Complete occlusion means you have no blood supply to the myocardium, and this means you have initially infarction distally to where the vessel supplies, and the infarction will progress proximally very rapidly until you get a transmural infarction. Transmural means essentially trans, which is across, mural, so across the whole myocardium essentially. With a transmural infarction, you can also cause damage and rupture of the papillary muscles here, which help the heart valvular function. Damage to the papillary muscles results in other complications such as mitral regurgitation or mitral prolapse. With a transmural infarction, it is very important to also look for ECG findings which suggest a new left bundle branch block. To find a left bundle branch block, just remember the name William. The L in William suggests a left sort of bundle branch. The W and M of William tells you what features to look at leads V1 and lead V6 on the ECG. In leads V1, you see a widened QRS with a W shape or pointing down. And V6, you see a widened QRS in an M shape or the QRS pointing up. A new left bundle branch block may suggest infarction of the septum of the heart, where the left bundle branch goes through. Remember, the septum is also supplied partially by the left anterior descending artery. Finally, let's talk about the cardiac markers. In a STEMI, you see elevation of cardiac markers. Similarly, in a non-STEMI, you also see elevation of cardiac markers such as troponin. But in an unstable angina, you got none. You got no cardiac markers. So let's just say you're at the emergency department and someone has presented with the signs and symptoms and the risk factors suggesting acute coronary syndrome, specifically a STEMI or a non-STEMI, a heart attack essentially. and you've performed the investigations and diagnosed a STEMI or non-STEMI. And you've done this because you looked at the troponins and the ECG findings. Now, the management of acute coronary syndrome may differ depending on what country you're in, but essentially, it's easily remembered as moan, such as moaning. And this is performed on all suspected cases of acute coronary syndrome. And this includes M for morphine, or specifically for opioids, intravenously. O is for oxygen, if the oxygen is low. A is for aspirin, as well as clopidogrel, to protect the heart from further insult, as well as nitrates to reduce the workload on the heart and to allow for more oxygen flow to the heart. So the initial management was moan, but what's next? So after the initial management, it is the definitive management. So in a STEMI, the ST segment elevated myocardial infarction, emergency reperfusion is commenced. The first choice or first line is primary percutaneous coronary intervention, also known as PCI. This is where an angiogram is performed. The occluded segment is cleared with a balloon and a stent inserted to allow blood flow back to the myocardium. A PCI is always first choice. However, PCI is only good in a certain time frame as a general rule. And the faster the time, the faster the better. But if a PCI is not available at a hospital, or if it will take too long to get to the place where the PCI is, or if the person presents too late to the hospital, then it is recommended to go for the second choice, which is fibrinolytic therapy, also known as thrombolysis. And as the name suggests, you are breaking down the thrombus, lysis as in breaking down. Agents used include streptokinase, alteplase, and retiplase. Now, streptokinase is not as popular now because I think it's been shown to cause some reactions in some people. The definitive management for unstable angina or non-STEMI depends on risk stratification. The risk stratification will basically tell you whether the patient requires a certain medication or a certain intervention, or whether monitoring is good enough. So for example, a high-risk person should be commenced on antiplatelets, anticoagulant therapy, and beta blockers. You can consider glycoprotein 2B3A inhibitors and revascularization, which includes angioplasty and stenting as well. However, the low risk and intermediate patients require just continuous monitoring of cardiac markers and ECG to see if any changes will occur. And if there are changes that might suggest them being high risk, then they go to the high risk management, and that should be commenced. However, after a while, if no changes has occurred with blood tests and ECG, a follow-up cardiologist review is suggested. And therefore, ongoing management after everything is resolved of all acute coronary syndromes include 1, lifestyle modification, which includes quit smoking, reduce alcohol intake, have a healthy eating habit, lose weight, and exercise regularly. Pharmacological therapy, ongoing, can be remembered with the mnemonic ABAS. So A is for ACE inhibitors or angiotensin receptor blockers, which help reduce blood pressure and also help reduce workload of the heart. B is for beta blockers, which help blood pressure as well as heart rate to an extent. A is for aspirin and clopidogrel to help prevent clots from forming. S is for statins to help reduce cholesterol. In this part of the acute coronary syndrome video, we will look at the changes that occur in an ST elevated myocardial infarction over time. So looking at the pathological changes both microvascularly and macrovascularly, and then look at the ECG correlation as well as complications of a myocardial infarction. So here is the cross-section of the heart, the right ventricle and the left ventricle. Coronary arteries surround the heart, and here's the pericardium which wraps around the coronary arteries as well as the heart. Zooming in from where the left anterior descending supplies the anterior wall of the heart, we can see here is a STEMI which has occurred. In a STEMI, there is occlusion total occlusion of the artery that supplies the area of the heart, and essentially a transmural infarction has occurred. The infarction occurs distally to the vessel and then progresses proximally unless the occlusion is stopped or resolves. The changes occurring straight away following an occlusion and till up to 12 hours include cardiomyocyte undergoing coagulative necrosis, and then subsequently edema occurs around the area. This is essentially the beginning of an inflammatory process. The ECG changes, as we suspect initially, as a peaked T wave, followed by an ST segment elevation. About 12 to 24 hours after a STEMI, you have continued coagulative necrosis, and a transmural infarction has already occurred. You begin seeing neutrophils, which are innate immune cells, infiltrating the area. The heart tissue is a site of inflammation and damage. ECG changes during this time still presents with an ST segment elevation, which may already form a pathological Q wave as well, and plus minus inverted T wave. Within the first week following a STEMI, there is cardiomyocyte death. There's necrosis of neutrophils as well, which have ruptured and died. And so the whole area is just messy. And this is where the macrophages start coming in to clean up the area and pick up the debris. The fibroblasts also begin to infiltrate and mature there, depositing collagen and other tissue matrix to the area to essentially repair the area, repair the myocardium. ECG changes during the first week include a pathological Q wave and T wave inversion. Weeks to months following a STEMI, you have fibroblasts forming a lot of collagen and depositing a lot of collagen there, forming scar tissue. The person may show evidence of a pathological Q wave on ECG, a sign that he or she has had a previous myocardial infarction. Finally, let's talk about complications following a myocardial infarction. So complications post-MI can be divided into early complications occurring within the first week following a myocardial infarction, or late complications occurring weeks after an MI. Early complications that occur within the first week include arrhythmias, specifically tachycardias, sinus, VF, AF, or bradycardia, such as sinus bradycardia, and heart blocks. Myocardial rupture can also occur. This includes rupture of the ventricular septum, which can later lead to right-sided heart failure. There can be rupture of the left ventricular wall, which can cause blood to pool within the pericardial sac, causing a cardiac tamponade. Or you can have rupture of the papillary muscles, which can lead to mitral regurg or mitral prolapse. Early complications also include acute heart failure, which usually occurs early, very early. For example, causing a left ventricular failure, which can then subsequently lead to cardiogenic shock, plus minus death. There's also pericarditis and pulmonary embolism, which can occur. Late complications occur weeks after MI and include a type of pericarditis called Dressler's syndrome, which is pericarditis following a cardiac intervention or cardiac surgery. And then, of course, another long-term complication post-MI is chronic heart failure.